This is Table 55.6, the International TNM Staging System for Lung Cancer. Medical students and surgical trainees spend countless hours attempting to memorize its rigid criteria, row by row. This table is more than a checklist. It is a highly specific, three-dimensional physical map. Treating it as a text file is a pedagogical error. These staging rules are enforced in a precise anatomical environment. The thorax is a dense architecture of vessels, nerves, and connective tissue. We are going to reconstruct the TNM criteria from the ground up, using first principles spatial logic to map the disease. Accurate staging dictates the line between a curative resection and a highly morbid, unnecessary thoracotomy. Getting this wrong subjects a patient to immense physical trauma for zero oncological benefit. The core rule of the TNM system is mechanical. A tumor's clinical stage is dictated by the precise anatomical boundaries it physically intersects. Mastering oncology staging requires abandoning rote memorization in favor of pure, three-dimensional spatial visualization. Before imaging even begins, a patient's clinical presentation acts as a preliminary physical coordinate. This table outlines the National Institute for Health and Care Excellence guidance on referral for suspected lung cancer based on specific patient symptoms. Centrally located tumors present early. As they expand within the major airways, they trigger mechanical symptoms like persistent hemoptysis or stridor. Peripheral apical tumors behave differently. Isolated in the upper lobes, they can grow silently, devoid of airway obstruction, until they invade adjacent local structures. This chest radiograph reveals a large mass in the right upper lobe, an apical tumor that presented clinically as Horner syndrome. Horner syndrome occurs when the tumor mass expands outward to physically compress the sympathetic nerve chain at the apex of the lung. By identifying the specific nerve deficit, we map the symptom directly back into our foundational 3D model, plotting the tumor's exact coordinates. Identifying these physical signals of invasion defines the T-stage boundaries long before a surgical incision is made. A patient's symptom is a definitive anatomical coordinate indicating the precise physical extent of tumor invasion. Returning to the staging table, we apply this logic to the primary tumor criteria, proving that anatomical landmarks supersede raw dimensions. The baseline T1 stage defines a tumor 3 centimeters or less, completely suspended within healthy lung tissue. Progression to T2A allows for raw volumetric growth up to 5 centimeters, provided it maintains those exact same anatomical boundaries. The critical exception to the sizing rule is the visceral pleura, the thin membrane encapsulating the lung. Regardless of how small the tumor is, its clinical stage automatically upgrades if it physically breaches this barrier. This invasion demands a wider surgical approach. A simple wedge resection is no longer viable. The surgeon must commit to a lobectomy for clean margins. The T3 criteria is met when the tumor expands further outward, contacting and invading the rigid chest wall or the phrenic nerve. A T3 invasion requires the en-bloc resection of the chest wall itself, including the affected ribs, significantly increasing the complexity of the operation. For central tumors, operability depends on clearance. A tumor must remain at a safe distance from the carina to allow the surgeon enough healthy tissue to close the airway. The T stage is defined by the rigid anatomical walls the tumor breaks, not merely the volume it occupies. The physical mass is only one variable. Staging must also track the silent, regional spread of the disease through the lymphatic system, the end stage. This diagram illustrates the nodal stations required for staging, categorizing the lymphatic drainage pathways relative to the bronchial tree. N1 disease indicates spread to the ipsilateral peribronchial and hilar nodes, directly adjacent to the affected lung. N1 represents a local containment failure. The cancer is mobile, but it remains within the immediate regional drainage basin and is generally resectable. Translated into our spatial model, we see the localized threat. N2 disease occurs when the metastasis travels inward, reaching the ipsilateral mediastinal or subcarinal nodes. N2 carries immense prognostic weight. The malignancy has advanced deep into the central chest cavity, placing it dangerously close to the systemic circulation. The definitive boundary of surgical resectability is drawn at N3 disease. When the metastasis physically crosses the anatomical midline of the trachea to infiltrate contralateral lymph nodes, surgical cure is abandoned for systemic therapy. The end stage maps a progressive timeline of systemic escape. Crossing the midline is the threshold where the surgeon's scalpel loses its efficacy. Viewing the T-stage expansion and the N-stage nodal spread simultaneously gives us a complete spatial map of the patient's disease. This creates a critical surgical dilemma. We must confirm the status of these deep mediastinal nodes definitively before we open the patient's chest. This illustration details endobronchial ultrasound, or EBUS, a vital tool for staging lung cancer. EBUS works by passing an ultrasound probe down the airway, allowing the physician to visualize and pass a fine needle through the bronchial wall to biopsy enlarged mediastinal nodes. This capability allows us to physically interrogate those critical N2 and N3 disease boundaries we mapped earlier. Confirming N3 status via EBUS prevents a futile, high-risk thoracotomy for an unresectable tumor. The staging criteria now read as a direct reflection of the three-dimensional anatomy we have constructed. Visual spatial intuition provides clinical clarity that rote memorization cannot match. Building this mental three-dimensional map allows for precise operative planning, matching the intervention to the exact anatomy of the threat. Final resonant tone. Surgical expertise rests on the ability to visualize a patient's internal anatomy and respect the physical boundaries of the disease.